In the previous lecture we discussed an introduction to angina, the symptoms associated with it, the 3 types of angina, then finally an introduction to the drugs used for it. So in this lecture we'll start discussing the drugs in details. We said that to manage the symptoms of angina, we need drugs that help to balance the cardiac oxygen supply and demand. And this is done by affecting blood pressure, venous return, heart rate, and contractility. And we said there are 4 types of drugs that can do that, when given alone or in combination. Beta blockers, calcium channel blockers, organic nitrates, and the sodium channel blocking drug, ranolazine. Let's first start by beta blockers. They act by blocking beta-1 receptors, resulting in decreased heart rate, contractility, cardiac output and blood pressure. So they decrease the oxygen demand of the myocardium, during exertion and at rest. So, what beta blockers can do, is that they can reduce both the frequency and severity of angina attacks. And they can be used to increase exercise duration and tolerance, in patients with effort-induced angina. They also reduce the risk of death and myocardial infarction, in patients who have had a prior myocardial infarction. And also improve mortality, in patients with hypertension, and heart failure with reduced ejection fraction. Propranolol is the prototype for beta blockers, but it is not cardioselective. As we already know that the non-selective beta blockers, block beta-1 receptors in the heart, so they decrease the heart rate, as well as blocking beta-2 receptors in the lungs, causing bronchospasm. For further information feel free to watch beta blockers lecture, the link will be down in the description. So, other selective beta-1 blockers, such as Metoprolol and Atenolol, are preferred. Non-selective beta blockers should be avoided in patients with severe bradycardia, and in patients with asthma. However, selective beta-1 blockers can be used in patients with diabetes, peripheral vascular disease, and chronic obstructive pulmonary disease, as long as they are monitored closely. Because all beta blockers are non-selective at high doses and can inhibit beta-2 receptors. You should know that beta blocker therapy shouldn't be suddenly stopped. The dose should be gradually tapered off, over 2 to 3 weeks, to avoid rebound angina, myocardial infarction, and hypertension. Calcium channel blockers used for angina are divided into 2 groups: dihydropyridines and non-dihydropyridines. Dihydropyridines, such as Amlodipine and Nifedipine. They act mainly as arteriolar vasodilators. They has minimal effect on cardiac conduction. The vasodilatory effect of Amlodipine is useful in the treatment of variant angina, caused by spontaneous coronary spasm. Nifedipine is usually administered as an extended-release, oral formulation. Non-dihydropyridines, such as Verapamil and Diltiazem. Verapamil slows atrioventricular conduction directly and decreases heart rate, contractility, blood pressure and oxygen demand. It has greater negative inotropic effects than Amlodipine, but it is a weaker vasodilator. It is contraindicated in patients with pre-existing depressed cardiac function, or AV conduction abnormalities. Diltiazem also slows AV conduction, decreases the rate of firing of the sinus node pacemaker, and is also a coronary artery vasodilator. It can relieve coronary artery spasm, and is particularly useful in patients with variant angina. This category of drugs should be avoided in heart failure, as they can worsen the case, due to their negative inotropic effect. That's all for this lecture. In the next lecture we'll continue discussing the drugs used for angina, so subscribe and wait for the next lecture.